And one thing that's interesting that you said is people would just say, oh, straighten your back when you're doing a back squat. And it's like, well, I can't. It's...
You can't explain can't.
Yeah, they're like, just do it. It's like, I can't. And that's a big thing with especially my kyphosis patients, because their parents have been telling them to sit straight or sit up straight. But the problem is, what does that mean? Like, a lot of times they don't know what that means. They can't get to that position. And so until we train the muscles in the body how to get in that position, it's kind of an unfair ask to sit straight, right? Or to do a back squat without your kyphosis rounded. So let's go into what can I do for scoliosis? Like, what treatments are available, positives and negatives to them, and who is appropriate for those. So really it falls into 3 categories. We have exercise treatments, we have bracing treatments, and we have surgical treatments. Okay? So there are some other things I'm not going to cover, like chiropractic and acupuncture and things like that. I only included the things that have more research behind them, so because I feel comfortable suggesting those things. So let's talk first about surgery. Sometimes it's necessary. Surgery continues to improve over time, especially in adolescent scoliosis. They're trying a lot of different surgeries in adolescent and juvenile scoliosis. Just to give you an idea, they're doing a surgery called VBT, which is where they put a tether on one side of the spine to stop it from growing on that side so that the opposite side will grow. So we can use growth in that aspect to reduce the scoliosis. I have a girl who, she was at a 35-degree curve. She's down to a 12-degree curve with VBT, which is kind of cool. But you have to have a lot of growth left, and you have to be the right curve size. So it's kind of a small window with that. But there are new things like that. That's not fusion. They have full flexibility of their spine, which is cool. It is a complex surgery, though. They have to deflate the lung, and they have to go in. It's big surgery. In adult scoliosis surgery, there's not as much progression with that. There's not as many new options. It's basically fusion with adult scoliosis and most adolescent scoliosis. It's still where they put in 2 rods and then screws into each vertebrae, and they stop it from progressing because it can't progress if it's fused. And then over time, the bones they actually take the discs out, and so the bone will actually grow in between, and so it's basically one bone at that point. So that's what a fusion is. Fusions are successful surgeries. I've seen that all of the surgeons in the state for adolescent and juvenile scoliosis I know really well, and they're all great surgeons. But adult scoliosis, there's a wide range. There are those who want to do a single level fusion in scoliosis patients, which I think is a bad idea most times. There are ones that don't do scoliosis fusion that often. And in my opinion, if you aren't doing it consistently, then just like a knee replacement, I wouldn't go to a guy for a knee replacement who's only done 5 of them. I'd want to go to the guy who's done 500 of them, So picking a surgeon is very crucial. I know all the scoliosis surgeons in the state, and adult-wise, there are some that I like more than others. Same with adolescent, but I think most of the adolescent surgeons are good. So afterwards, if you have specific questions on surgeons or want an idea who to go to or something like that, I'd be totally happy to talk about that. But I'm not a surgeon. I do know a lot about surgery, but that's not really quite the purpose of what we're going to talk about today. So any other questions on surgery? But a lot of my patients, all the pictures in the clinic here are patients of mine with scoliosis. And I have a fair number of dancers, like ballet dancers, and some of them have a fusion and go back to ballet dance, which is kind of crazy to me, They still have the flexibility to do that, but they have to change how they do. Her name is Kyra Condi. I did a podcast episode with her a little while ago. She's an Olympic rock climber, and she went to Tokyo in the Olympics. And I did this podcast a few months after that, and she's the first Olympian who's had a scoliosis fusion, like ever, that's competed in the Olympics. And she said she had to change how she was moving and climbing, but she was able to do it. So it doesn't always mean that you lose a ton of mobility, but you are going to lose some mobility. So, okay. So there are a lot of questions on surgery. Maybe we can talk about that after. Bracing. This is a picture of a bunch of different types of braces. Bracing has gone from the Milwaukee brace back in the 50s and 60s, where it had a metal thing that went underneath your chin and pulled you up, and it was leather and all this stuff, to thermoplastic now that's more like this, and it can be concealed underneath clothing and stuff like that. So there are a lot of different options with bracing. Usually it's rigid material, plastic and metal, and we utilize growth modulation, where we're trying to bring the spine back to midline while the child grows, so that the spine grows more symmetrically. But in adults, I have not found a good option for bracing, because bracing causes some other issues. It can cause rib deformities. It's more uncomfortable. It can weaken the back. All those things. It's a bit more of a challenge in our adult population to do bracing. I do think a soft brace, like a supportive brace, can be helpful, just a regular back brace, but I don't have a great option as far as bracing for adults. With adolescents, we do it all the time, after they get to 25 degrees. So, but they can definitely be uncomfortable. And braces are expensive. These thermoplastic braces are like $3,000 to $5,000. So they can be pricey. Okay, so that's bracing. Exercise, I'm kind of biased towards exercise because this is what I do. This is what I do all day. 80% of my patients are scoliosis and kyphosis patients, and we use a specific method for that. This is important. I had a couple of surgeons that really were like, you need to make sure that you emphasize this. The general strengthening hasn't really been shown to affect the curve, the progression of the curve. So if you're looking to stop progression of the scoliosis, whether in adults or in adolescents, strengthening alone does not do that. It can reduce pain, it can improve function and things like that, but it does not, the research is pretty clear on that. It does not change the progression of the curve. So if we're looking at it not getting worse, strengthening is good, but it doesn't do that. So research is showing that it has to be a specific method of treating scoliosis. We have to treat the scoliosis specific to the curve in order to get the curve to respond. So I think it makes sense. We call it physiotherapeutic scoliosis specific exercise. It's a mouthful, so we'll call it PSSE. And there are a few different methods: the Schroth method, the Lion method, C's approach, Dobomed, side shift. I don't know anyone around here that does these two. I do the Schroth method and the C's approach, and the Lion method, there's some in New York that do that. But the Schroth method is by far the most researched of that, and has been shown in adolescents specifically that it can reduce the curve up to 5, sometimes even 10 degrees if it's done consistently. Of course, that's an average. Some people do better than that. Some people don't do as well as that. So it's interesting. All of these are in Europe. This is a German method. This is a Dutch method. This is an Italian method. I forget where those other two are. I don't know why the Europeans are further ahead than us on this, but the Schroth method has been around for 100 years. It just celebrated its 100-year anniversary last year. So it's been around for a long time, but I was the first one in Utah to do the Schroth method, which is kind of crazy to me, 10 years ago.
What sets it apart? Either the Schroth or the other. What sets it apart from different therapies there?
So I think the biggest thing is that they're a researched and studied method in addressing the scoliosis. So like let's say core strengthening, for example. Like you do planks and side planks and and other things to strengthen the muscles. Most of the time that's symmetrical strengthening. We can't treat an asymmetrical problem with symmetrical strengthening. Does that make sense? So we have to have a method that is specific to the curve. So for example, the Schroth method, we use different breathing techniques to open up the sides that are concave. We use different movements and different muscle contractions to get more correction as much as we can towards midline. And I mean, it's been around for a long time, but it's continually being changed and modified. So I think the biggest thing is that it's specific to each individual curve. Does that make sense?
Yeah, I guess.
Yeah?
As far as like the exercises, are they different? Do they vary a lot from one method to another?
These methods?
Yeah. Yeah.
Yeah, they're similar. They have similarities, but they each do their own little spin on things. At the international conference for scoliosis that I went to one in Boston in May, they're representatives from each of these, and it's interesting because they have their disagreements on, like, the C's approach doesn't do breathing expansion and derotation, but the Schroth method does, and so they have their little, you know, they don't talk trash about each other or anything like that, but they debate it a bit. So they each have their own little thing, like the side shift method is more just this direction side shifting. So they kind of sacrifice some of the derotation aspect of it. That's why I went with the Schroth method at first, because I wanted to hit all directions, all three dimensions of the curve, and I wanted to do it with something that has been researched and found to be effective. So I think that's the biggest difference with PSSE and any other treatment technique is I haven't seen research on any other treatment technique. So I don't know if that makes sense. Does that help?
Yeah, well, yeah.
Yeah? Okay. So that's exercise. Just talking about who's appropriate for PSSE. Adolescents and juveniles, slowing or stopping progression of the curve. It does reduce pain, but it also improves body image. Like, it improves the look of the scoliosis. If you think about the rib prominence on the back, the rib hump, we can see a reduction in that. We can see a reduction in the pelvic shift. In adults, we definitely see a reduction in pain as we get more balance and less asymmetry out of the spine. It can help to avoid surgery. I have patients who we've been going for, almost 10 years now, avoiding surgery with them. That's how long I've been open and been doing scoliosis treatment. And it takes work, but it is effective if you spend the time for it. It reduces progression and improves function. I have a patient who came in because her cardiologist said that her dysrhythmias that she was having in her heart were because of her scoliosis curve. She was like, I don't believe him, but she had a fairly big curve, 45, 50 degrees. And as we started doing some breathing techniques and that, she's been going strong without having any heart issues for a few years now. So there are definite benefits to that. So these are they're kind of hard to see from back there. These are just some results we see from specifically working on the curve, whether that's Schroth method or the C's approach. They still have scoliosis in the after pictures. We can't fix it, we can't take it away. It's there to stay once it gets above 10 degrees. But we see this is one that Corey, one of my therapists, sent me yesterday. He said, hey, check out how this kid's doing. And I don't know if you can tell, but his pelvis is way more balanced underneath him than this picture. So this picture, he's like this, and we're getting much better balance. And he's had a lot of reduction in his pain because we're seeing better balance. So this is a 16-year-old. We're seeing better balance here. We see, you guys can't read these, but 16 degrees down to 12 degrees, 20 degrees down to 15. Oh, that's the same picture. So we see a reduction in the curve, but it doesn't fix scoliosis, right?